All right, so in this module, we'll go over the intervertebral disc and some of the ligaments within the spine. So the intervertebral disc, typically we refer to that as the IVD, and you can see it's pictured here. Two functions. It's going to provide some separation from the vertebral bodies there and there. And then it's also going to, as this shows you there, it's going to help with absorbing load from the ground or from above. And we're going to often call this axial compression. So with that, the disc varies in width, obviously smallest at the cervical spine, about 3 millimeters, and then largest at the lumbar spine, 9 millimeters. Yeah, of that, a penny is about 19 millimeters in diameter or wide. So about half of a penny is the width, average height of a lumbar disc. And then the ratio is greatest in cervical, lumbar, and then smallest in thoracic spine. You have three parts to the disc. The nucleus pulposus is the portion right in the middle there. That's, so to speak, the jelly. In the surrounding that, you have the annulus fibrosus, the rings. The annular rings surrounding the nucleus, as you could see there. You have the vertebral endplates. I'll show you a better picture of that on an upcoming slide. The annulus fibrosus, should mention here, that it does have partial innervation, and typically it's understood that the outer 1/3 is the best portion of it that's innervated and the most susceptible to joint pressures, sort of like a guarding mechanism as the nucleus pulposus. If it were to migrate outward into there, the outer 1/3 of the annulus fibrosus would receive that input. Additionally, it should be mentioned later that the nucleus pulposus and the annulus fibrosus change significantly with aging, and a lot of these structures start to blend further. Also, I do mention that nucleus pulposus is more related to spine of any other portion. The cervical spine does not seem to have the nucleus pulposus. Thoracic is limited, but lumbar is definitely where this is most applicable. So one of the interesting studies they had a few years ago, back in 2015, was with NASA. And what they would do is they would take identical twins and measure them on Earth and then send one of them to space. So this is Scott Kelly. He spent 340 days on basically a zero gravity environment at the International Space Station. He came back to Earth, and as you can see here, saw his identical twin brother, and he was 2 inches taller when he came back. Wouldn't that be cool? But the rest of the story is that just 2 days later, after being on Earth's gravitational pull, he returned back to his normal height. And one of the reasons for the change in height is obviously the bones, your femur and your vertebral bodies and other bones don't lengthen, but your intervertebral disc does, because it's largely fluid-based, a lot of water within that disc, and without the compression, the water stays within the disc more hydrated. This is one of the same reasons that if we sleep, let's say we sleep 7 or 8 hours in a horizontal position in our beds, and then we wake up in the morning, we're typically about 1 inch taller in the mornings as opposed to other times of the day. And even with activities like running or jumping and things like that, there's been studies that show that decreases our height temporarily by 1/4 inch to 1/2 inch. Nothing long term, but certainly in the short term, it does decrease that. So that has some implications as you look at patients. And if there's a discogenic or disc-oriented pain, it's typically worse in the mornings. So worse in the AM because the disc is fuller. And that means if the disc is fuller, it's closer to the nerve root that it may be compressing or other things. And it's usually better in the evenings. So that's one hallmark symptom of disc-related pain. So that helps you with that. So as we look at the disc themselves, there's really three structures. First one we'll talk about is the center portion, the nucleus pulposus, which is largely water. It's about 80% water content, especially in our younger years. And then as we get into our 50s, 60s, and 70s, that water content gradually loses in our discs, in our skin, which is why we get wrinkles, and in other parts of our body, we lose hydration. Part of this is related to the presence of these glycosaminoglycogens, these GAGs, because those are the water attracting molecules within our body, within our connective tissue, and certainly within the disc and other areas. But the nucleus pulposus is really more of a cushion. It's not a lot of dense collagen. Water is the main substance there. So it's a good shock absorber, almost like a gel. So this could be contrasted to the annulus fibrosis or the AF. That is approximately 60% water. So still a lot of water. Think of this as like a gel, but more of a thickened gel or hardened gel. So still a shock absorber. And this goes in concentric rings. And like I mentioned before, the outer 1/3 typically is the innervated portion of the most. But type 1 collagen still predominates, especially in the outer portions. And it's important that if the nucleus were to try and escape, that the outer portions are the most resistant. So if you think about this like a fence, almost a perimeter, the outer perimeter is the thickest and the densest to keep that nucleus in. Because if the nucleus pulposus gets out, that's a foreign substance to the rest of the body, and the body tends to basically send more scar tissue and almost attack that because it doesn't know what it is. So it's not meant to be outside of the annulus. And then the third plate of the intervertebral disc would be the vertebral end plates. And you can see it's pictured there on each side. Makes this diagram makes it look a little thick, but it's usually a little flatter. And just like the nucleus and the annulus, it's made up of three parts, somewhat water, so water, collagen, and proteoglycans. So these are the three things in the vertebral end plate, and this really helps to provide some attachment. And there's some Sharpie's fibers right in there. We talked about that before, connecting the periosteum to the vertebral end plate, but also to provide nutrition from the bone to the annulus and the nucleus pulposus. So these are important structures. So the next part we'll talk about are the different ligaments that go throughout the spine. So this right here, this table from the book is a nice summary of the different ligaments and their overall functions and which motions they limit or how they're shortened and lengthened. So this is just a good summary of everything. So it'd be good to know this material for sure. So here we go. We got Kevin Bacon up here because you always hear about Kevin Bacon and the 6 degrees of freedom. There are 6 main spinal ligaments that we'll go over. Certainly, you can see these in anatomy and get these in anatomy. So this is just a real quick review rundown of the spinal ligaments. So the first ligament we'll go over is the anterior longitudinal ligament, or the ALL, which is obviously on the anterior portion of the vertebral body. You can see it pictured right there. And this travels all the way along the vertebral bodies, all the way from the sacrum, our tailbone, to up to the upper cervical spine to around C2, typically. It's best developed in the lordotic curves. So as you think about which cervical and lumbar areas have lordosis. So it's best developed in there. So those are the convex portions anteriorly, and that's where the ALL lives. And so for that reason, has little substance in the kyphosis of the thoracic spine. So that's the first one. Then on the other side of the vertebral body is the posterior longitudinal ligament, the PLL, so you can see it right there as it travels down there. And you can see this gives you a good appreciation for the thickness of the posterior longitudinal as compared to the anterior longitudinal ligament. But the PLL, because it's on the posterior side, it's going to be lengthened and flexioned and shortened as it gets into spinal extension. Question on which membrane replaces the PLL when it goes the upper cervical spine from seat to occiput. Let's go to the next slide. And so here you can see the PLL traveling up, and it forms into this membrane here, the tectorial membrane. And then this is just a summary slide showing the ALL and how that's shortened in flexion versus lengthened in extension, and opposite for the PLL. Then the last ligament we'll go over is a very important one, Ligamentum Flavum. It's also on the posterior side, but this, as you can see right there, is on the posterior portion, posterior to the spinal cord. So the spinal cord would be right there. This is directly posterior to that. And what's unique about the Ligamentum Flavum is it's highly elastic. This ligament is about 80% elastic in nature and only 20% more collagenous in nature. So this is a really stretchy, taffy-like substance, which allows for a lot of distortion from end to end. Of course, just like other structures, other connective tissue, it can become strained when pulled at from the distal end. And if you can imagine this on the posterior portion, so with spinal flexion, it is going to be stretched, and with spinal extension, it is going to be shortened. Okay, so we made it this far into the online talk, but I yet to mention the cheesy joke of the talk. So this one, another bar joke. So a mushroom walks into a bar, waddles over to the booth and says, "Bartender, get me." And before he can even finish a sentence, bartender said, "Hey, mushroom, we don't serve your type here." And the mushroom goes, "Hey, come on, I'm a fun guy." Fun guy. Okay, so there you go. Okay, back to the Ligamentum Flavum. So you can see here, this is a graph depicting the stretchiness. So you have the physiological range here, and then potentially, which is different than Ligamentum Flavum as the other, just at 50% strain, which is actually a lot for other ligaments because of the elasticity allows 50% strain of the tissue. Failure occurs around 70%. So that's a good number to know, that 70% is an increase from the starting point. So if the Ligamentum Flavum is 100 centimeters, you would stretch it up until 170 centimeters before it would actually fail or tear apart. So that's significant as opposed to other tendons or fascia or other ligaments within the body, significantly more. And then this is just some other ligaments that we didn't cover, but the interspinous ligaments connect the spinous processes. So these are going to be posterior, which means they're going to resist flexion between the vertebral posterior portions, as opposed to the supraspinous ligaments, which are really just even more posterior to that, to the very tips of the spinous processes. So these are going to take more flexion, hyperflexion, end range flexion to stretch out. So both of these are going to resist flexion, and they're going to be really shortened or compressed in extension. The transverse ligament are going to connect the transverse ligaments on each side. So on the right side, they are going to be shortened when going to the right. And so they're going to be shortened. And then when going to the left, they're going to be lengthened. And then also you have your facet joint capsule, which is really important. We'll talk more about this in class. But of all the ligaments and other structures that we like to test or work on, this is one of the most common ones that we can manipulate or mobilize with some manual therapy or other techniques. So those are the ligaments to cover, but look at the pictures, and if you just visualize where they are, you can typically conceptualize and think about what shortens them, what lengthens them, and how they would be tested and propagated. That's about it. Thank you.